Everybody, we're a bit late.
Hello? Yeah. And
Can
nikempata.
you mute those guys?
Ameniinstruct lakini ameniambia niende kwa
Oh. Kyoko, just mute those guys.
They're muted.
Okay. So today we are going to very quickly look at the management of epilepsy and a few other conditions. Now, for those of you who did not participate on Friday, was it?
sawa tu. Sijui kama kuna place kweli.
Kyoko, please mute that person. So for those of you who did not participate on Friday, we did mention that at this time we're going to use the same notes, but the focus will be different. In other words, the focus this time will be mainly therapeutics, as in what choice of drugs are we going to use and what will determine our choice of drugs, which will be drug properties, drug interactions, adverse effects, etc. So I'll be quite fast, but we'll be looking at a couple of areas. I will emphasize which areas would be important to help us achieve that purpose. So again, I'll not waste a lot of time with epilepsy. We covered last year, and we'll still cover this in 5th year. But basically, epilepsy is a condition that is a chronic condition. Although sometimes, depending on the etiology and the cause, it can be, you can have a drug holiday. So some of the causes include genetic causes, etc. And this is the presentations. I'm sure all of you maybe have seen an epilepsy patient. So depending on the presentation, so we are just going to use, like, I think this is DSM B3, DSM-3, I think DSM-4, I think, yeah. So these are some of the causes, including traumas, head injuries, birth defects, delay during birth, etc. Now, the reason why we have used the DSM-4 is that it's more relevant to pharmacology, settings, and management of drugs. DSM-5 is a bit more complicated. In other words, it features more of a clinical presentation more than it's not very relevant to, or rather it's not appropriate for the drug use. So here, there are two types, that's partial and generalized seizures. We've covered that, and you can still go through your notes. The partial and complex seizures and the general presentation, and then generalized tonic-clonic seizures, and then absence, mainly from French, or absent seizures. This is the presentation. Now, going back to classification of seizures, again, to enable us describe the drugs that are used for epilepsy. Again, for partial and focal seizures, basically arise in the cerebral hemisphere. Simple partial, there is no alteration of consciousness. Complex partial, there is altered consciousness. And so you can go through all this. And then generalized seizures would be mainly classified as per the presentation. In other words, tonic-clonic, where there's muscle tone, myoclonic, etc. Now going to the drugs for partial seizures. Again, we did classify last year, but this time the focus will be a bit different. I want you to notice that valproic acid is broad spectrum. In other words, it can be used for partial seizures, it can be used for generalized tonic-clonic, as well as absent seizures. And then, of course, drugs for status epilepticus is a fairly medical emergency. So generalized tonic-clonic can be classified as status epilepticus depending on the duration, basically. So if you can go back, that's as per our definition. Generalized tonic-clonic seizures may last for up to 5 minutes. So it's basically a general emergency. Now, in terms of what we know now, the focus mainly has been to try to calm the patient, in other words, to control electrical activity in the brain. As you are all aware, sodium channels are very important. So if you can block the sodium channels, if you can also block the thalamic channels, or GABA can inhibit neurotransmission of GABA, then you can treat epilepsy. But the current thinking, like we said last year, is we can also you can interfere with the NMDA receptors. And I think last year we did give examples pretty like in a manner just like the way you would treat arrhythmias. So in terms of the mechanisms, again, these are the main mechanisms. That's calcium ions. Then you can also stimulate GABA in order to increase the GABA blockade, and reduce brain activity. And then finally, you can inhibit glutamate neurotransmission, which is really all the thinking for drugs like felbamate, etc. So there you go again, the mechanisms. I'll not waste a lot of time on that. And the examples of drugs like voltage gated sodium channels, those are the drugs, carbamazepine, lamotrigine, etc. At this point, I would like to mention something with regards to therapeutics, that whereby if you're going to use two drugs, you are likely to use a drug that would have different mechanisms of action other than using drugs that have the same mechanism of action. Why is it important to do so? A class rep, can you help us today? Why would you want to use two drugs with different mechanisms?
I'll think of probably additive and
Who is that? Is that Ian? Okay,
sorry?
anyway, go
Ian.
on. Oh, Ian, okay, fine, go on, yeah.
Oh, I'm Satya, sorry.
Yeah, oh you are such.
Yes.
Okay, I wanted Ian this time, but okay, go on.
So I'll think for additive and synergistic reasons, purposes, to increase the effect. So
Yeah,
as to
all of them
control the condition
would
better.
still have synergistic action, but why would we, in terms of therapeutics, why would we want to use drugs with different mechanisms of action? Maybe EM can help us this time.
The reason we use different drugs is because first we want to reduce the side effects of each drug, and then we have one drug can act like an adjunct to the other so that we increase the therapeutic effect of the main drug.
Yeah, so your first part of your answer is correct. Because in terms of therapeutics, if you're going to use two drugs, like carbamazepine and lamotrigine as adjunct, and probably they have the same mechanism. I'm not saying they do, but if they have the same mechanism of action and probably adverse effects, then the adverse effects would be exacerbated, isn't it? So you probably want to use one with a different adverse effects and probably different mechanism of action in order to prevent resistance, number one, because you're using drugs with different mechanism of action. So if a drug is resistant to one, then it's not likely to be resistant to another one with a different mechanism of action. So there you go. Those are some of the effects. And then, of course, the drugs that deal with the GABA systems, in other words, stimulate GABA like benzodiazepine, and therefore increase the inhibitory action. Topiramate is a drug that, again, is an adjunct drug, but has the same mechanism as benzodiazepine. So unless you really have no option, it would be better to combine benzodiazepines, say with a drug with a different mechanism of action like lamotrigine. Again, these are the drugs that, again, glutamate, Felbamate is one of the oldest drugs, but now people are looking at this mechanism through NMDA, and new drugs that are less sedating, which is a major adverse effect for drugs for management of epilepsy, are being formulated. So if we go back to the drugs now, starting with carbamazepine, I'm not really going to go very much through the mechanism of action, which will be sodium channels. But in terms of therapeutics, now you have to concentrate on the adverse effects. Now, the key adverse effects, of course, include CNS depression that will lead to stupor, coma, drowsiness, and respiratory depression as well. So, in terms of therapeutics, I would probably want to ask you a question about the drugs that cause respiratory depression. And I might barbiturate, for example. So I would want you to tell me, could you combine carbamazepine, say, with a barbiturate or another drug which I know that has respiratory depression? And so you have to be aware of that could be contraindicated. The other issue is hematological toxicity. We may have nothing about that. And also teratogenicity, but more importantly, enzyme induction. So I might want to ask a question in terms of therapeutics about co-administration of carbamazepine with, say, a drug that is a substrate for cytochrome P450 enzymes. So since you cannot avoid using carbamazepine, then you'll have to give me options. What do we do? Okay. Do we have any questions up to that point? Because I want us to understand the basis of therapeutics. So it's important, this is just a guide. I want you to go back to your notes, look at the adverse effects of carbamazepine and other drugs, and which drugs should not be co-administered. Sometimes you don't have an option because there will be no other drug that you can use. In terms of phenytoin, again, the mechanism of action is still the same, but it generally has more adverse effects, including purple glove syndrome, which can be life-threatening sometimes. Again, it interacts with several drugs through enzyme induction. So I might want to give a theoretical case whereby a patient has hypertension and epilepsy. And I might want to give you a case whereby the patient is actually on the same drugs. And then you would have to inform me whether it is safe to use, to co-administer or not, and what options are available. So that's really what would be important in therapeutics. So in terms of therapeutics, I'll not ask you to name the adverse effects. I may, but sometimes I may want to ask a more specific question whereby you have to correlate different drugs via adverse effects, mechanisms of action, etc. Sodium valproate, again, the adverse effects include hepatotoxicity, but generally, we did mention last time that it tends to produce the least sedation compared to the other drugs, and it's also wide spectrum. Primidone, we mentioned that this drug has been discontinued, although it's still first line in the treatment of essential tremors, whereby it's used with the beta blockers. And here again, in terms of therapeutics, you have to remember the blood dyscrasias and several other serious adverse effects like SLE. So if a patient, I might be interested in a situation whereby a patient has HIV and essential tremors. So it's up to you to understand what's going on. And if you are going to, if you must use primidone and an antiretroviral, what is required? That's what basically I would be interested. Would you require to reduce the dose of another drug, or what options do you have in terms of therapeutics? Phenobarb, again, this is a cheap and widely used drug, especially in our setup. We've discussed a lot about barbiturates, but again, you must remember about that barbiturates can cause porphyria, especially for predisposed patients. So in terms of therapeutics, that has to be in your mind all the times. So I may want to present a scenario whereby a patient has a history of porphyria and with epilepsy, and I may want you to give me an option of what drugs may be used. So with the adjunct drugs, again, the drugs are the same, but again, now this time, you must understand the mechanism of each of the common drugs. Like I've said, much as you may, especially in our settings, but we want to understand the kind of drug-drug interactions that occur. For example, if you're using lamotrigine and carbamazepine, They may have the same mechanisms of action and then the same toxicity. And so there would be risk of resistance, number one. And then number two, again, the adverse effects may be exacerbated. Topiramate, again, has a dual mechanism of action. Gabapentin, we don't use it much for epilepsy, mainly for pain. But again, you may use it as an adjunct drug. So you must, it's good to remember the mechanism of action, in this case, GABA. Pregabalin, in our settings, we use it mainly for trigeminal neuralgia, pain, and other neuropathic pains. But again, in terms of therapeutics, it's important to understand the mechanism of action. The next drug, levetiracetam, is now available in the Kenyan market. And it is also, you must remember at least the basic mechanism of action. So kindly go through all of them, the common ones, and then generally have a look at the mechanism of action with a view of understanding whether it can be co-administered with the major drugs. Are there any questions up to that point?
Prof, I have a question.
Go on.
Still on the same issue of co-administration and the issue of side effects.
Yes.
So you see, some of the side effects are contradictory, as
Yes.
of the two different drugs.
Yeah.
So can you also use that as a factor to consider? For example, we find that phenytoin causes hirsutism.
Yeah.
Or valproic acid causes alopecia.
Yes.
Then valproic acid is also an enzyme inhibitor, as we've seen, while phenytoin is an enzyme inducer. So can you also combine the two to nullify the effects, or it doesn't work like that?
No, no. First of all, when you are treating epilepsy, are you really bothered about the hair? I mean, that's your least concern, isn't it? Now, Kyoko, it will end in 10 minutes, so you know what to do. We'll all, it may not be your major issue, but it's a good question still. So, first of all, let's look at a true scenario. So you are looking at the main drug. So you're not going to combine valproic acid. You can actually, There's even a case, somebody is being sued for that in a child, you probably saw in the news. But we're looking at a situation whereby you're using the main drug and an adjunct drug, okay? So that is where the indication is, as in you cannot use the main drug and another main drug unless you have resistance, okay? So we would want to look at an ideal situation whereby you have the main drug and an adjunct drug, and use one, the adjunct drug should have different, adverse effects and different, that have different adverse effects and different properties to try and reduce the adverse effects. So the main intention here is to reduce the adverse effects, okay? But in terms of, as I know, maybe have you started your junior clerkships?
Yes.
Yes. So you'll realize that in the ward, there are so many other issues. Those may be the only available drugs, okay? So you have no option. But if you have an option, at this point, we want to teach you in therapeutics, whereby if you have, it's just like you have 3 or 4 antibiotics. So you want to choose which is the best. which one can I combine with an antihypertensive drug that the patient is taking? Okay, so do you understand those scenarios?
Yes.
To reduce the adverse effects. But if there is no other option, yes. But in terms of therapeutics, now that we are not on a practical session and we are teaching you, we want you to try and remember as much as possible which drugs should probably not be co-administered. Have I answered your question?
Yes, Prof.
Okay, any other question?
Yes, I have a question.
Go on. Who is that?
Ian.
Ian, yes, go on.
So we've seen that most of these drugs have adverse effects like teratogenic or something to do with pregnancy. So I'm asking, is there a drug of choice for treating epilepsy in pregnancy?
That's a good question. Now, there is a golden rule in medicine. You probably heard about it. You weigh the benefits against the risk.
Yes.
Okay?
Yes.
So those are very tough clinical decisions that you must make sometimes, unfortunately. So number one is that all these drugs have serious adverse effects. All of them would cause drowsiness, most of them are teratogenic, actually, like almost all of them. But then, if you have a mother that has epilepsy, Ian,
yes,
you say that you don't want to treat her because she's pregnant.
No, you'll have to treat her.
That's why you're going to be a doctor. You have to make those decisions. I will end my answer there.
Okay.
So it depends on the situation, the presenting situation. Okay?
Okay.
So you might want to use a drug that has less effects on less teratogenic effect. And that is why you guys are fourth years. The university has we have this online system now which everybody can use. What do you call it? You can quickly check drug-drug interactions, etc., and that will help you very much. Okay.
Okay.
All right. What do we call? I think it was circulated to everybody.
No, we didn't get it, but we shall look for it.
It's there. It's up to date.
Yes, we have it.
You have it. So you should be able to, in the ward even, you should be able to quickly check the drug-drug interactions. That will help you in terms of practice. All right. So learn to use your up-to-date. The last question before we move on. Okay, so Vigabatrin and Felbamate, these are drugs that are adjunct drugs, but the reason why I've separated them is that they may be used as standalone alone. By the way, even the adjunct drugs may be used alone, of course, depending on the presenting condition or the condition of the epilepsy. So Vigabatrin, again, we've discussed the mechanism of action and then the indications. So this one may be used alone in children, but it's also an adjunct drug. What's going on, Kyoko? Okay. So sodium felbamate, this is one of those drugs that is very potent. It's an old drug. It was used in the 60s, but but it causes aplastic anemia that is fatal and acute hepatic failure. And therefore this drug, that's why it was stopped. But it is now used in resistant epilepsy, which in terms of epilepsy, we would want to use the term refractory. So where all the other drugs have failed, we can use this drug. But again, always remember that it causes aplastic anemia and hepatotoxicity, which of course are serious adverse effects. Felbamate also, the mechanism of action is activation of NMDA receptors. And like I said last time, now there are several drugs that are being developed now that do not act exactly like Felbamate, but would prevent that initial peak so that the electrical activity in the brain can be reduced. Just like, I think I gave you an example last year, like the way you treat arrhythmias, just by blocking the sodium, like wave, the initial wave. And those, many people think that those drugs are really going to be ideal because they are not, they may have a few adverse effects, they may be more potent, and more importantly, they would not cause drowsiness. Because one of the main problems of using antiepileptic drugs is you interfere with the day-to-day activity of the patient. Like if you're a student with epilepsy, it becomes a challenge because you may be having drowsiness and therefore you cannot understand pharmacology. So in terms of absence drugs, ethosuximide is the key drug. It has few adverse effects, but still I want you to remember the adverse effects in terms of therapeutics. Clonazepam is a short-acting benzodiazepine, which is also used for epilepsy. Again, I want you to go in more details. So finally, the choice, initially you use one drug and then increase to use 2 drugs. So ideally it would be the main drug plus an adjunct drug. And then of course, what we have mentioned here, use 2 drugs with different mechanism of actions to prevent resistance. And if possible, that have different adverse effects. The list, this is the general list. I think we should change this. In our set